So this is the case of a middle-aged man with Fuchs dystrophy, where we've chosen not to perform Phakic DMEK, but instead just the DMEK. We're doing the case under a retrobulbar block, and we are not using an AC maintainer this time because we found that the AC is quite stable under a single air bubble injected through a paracentesis. The graft size to be injected is 7.75, so we've marked the cornea at 8 millimeters, and now we're stripping desmase under air with the reverse Sinskey hook. And as is sometimes the case in Fuchs dystrophy, especially when the dystrophy is medium to advanced, the desmase membrane comes off quite nicely as a sheet instead of dividing into multiple little fragments that are more difficult to take out. And it's quite satisfying to remove the whole of desmase in one single piece rather than have to go fish for multiple small lingering peripheral tags. So we've refilled the AC through our left hand paracentesis, and now when we're satisfied with the desmetorexis, we're removing the whole tissue through the main wound. And because we haven't set up the phaco machine with the INA or the vitrector, we're just washing out the air. The donor is quite young, he's 55, so we're expecting a tighter roll, which is actually handy in a shallow AC because you can more easily tell the orientation, and it's not that difficult to unfold a young donor in a phakic case because the AC will be shallow, so your taps will be effective, as will be visible in the following seconds of unfolding. So we've tried to inject the graft in a correct orientation from the get-go, but it kind of came out as a single roll, and that isn't always easy to inject right side up. But as it will soon be apparent, we got lucky in the sense that we have an edge to our left, which we're keeping pinned with our left cannula, and we're slowly trying to at the same time unfold the roll and keep it centered. So what we're doing now is using our right hand to nudge the graft over to the left hand side so as to be able to pin that edge that has easily unfolded, and then using derisomer taps to simply unroll the central scroll. But sometimes what happens is that the whole graft moves if your pin is not firm enough. But this is not really a problem because you can shift the graft over with compressive taps as shown here. And now after a few tries, the graft unfolds very nicely. And after we've done that, we have to secure the graft with security orientation, so we use a small bubble and then deepen the AC through the right hand paracentesis with BSS. And now we're trying to perfectly center the graft because centration is quite important for adherence purposes, because if there is overlap in the periphery, the graft will not stick easily, and there's of course an increased risk for post-op detachments. So we want to avoid that, so perfect centration is necessary if possible in all cases. And that's the airfill, and that's the case. Thanks for watching.